right, this is the station where we are going to discuss respiratory. We're going to go over all different sorts of devices, what leader you would put it to on the wall, and how to apply to the patient, things like that. I guess we can start here with this incentive spirometer. You guys have seen this before. Like I said, we talked about how each facility is independent, may look slightly different, but the use is exactly the same, okay? This over here is just kind of like our goal that we go to. And then this comes off. You instruct your patient to put their lips around the mouthpiece. I'm not going to do this because it is not mine. And then do you suck or blow out of this mouthpiece? The patient gets confused every time, so you need to make sure that you know that you're sucking in. Okay, so I like to instruct my patient to do this. They pretty much always have the TV on in the room. So I like to say, every time a commercial break comes on, perform this exercise during the commercial break, okay? So they put their mouth around this, suck in for a long amount of time. You're not just and then done, right? You're wanting them to suck in gradually. This little thing goes up and down as you suck. And then as soon as you get their goal, this is like the goal mark, okay? So you just put it where you want them to reach into. So this will go up as they are performing their inspiration, okay? So that's just our tool here. We'll go over that more in lecture, things like that, but this will be something that you can educate your patient on. All right, so we'll start on the oxygen devices, going from the least to the greatest here, as in need, okay? So first start with our nasal cannula. All right, this is how it's packaged, like in the supply rooms or at bedside. So it kind of looks a little different than what you may be used to, but it says adult nasal cannula, okay? Just rip into the package here. All right, it's trash. So as you can see here, you untangle all this. You have the two prongs, right? All right, that is what is applied into your patient's nares. Now, as you can see, there's a little angle on them. Can y'all see that the angle? There's like a downward angle. You can see how it's kind of up like that. Okay, you want to apply it to your patient where those little prongs there are going downward into their nares, okay? So you want to make sure that this is put onto your patient. You're going to be gentle here. Obviously, I perform hand hygiene and have gloves applied, right? I like to put it inside my patient's nares first, okay? And then it goes up and around each ear. And this right here may need to be adjusted here. So up and around an ear and around the other ear, and do so gently so you're not pulling on your patient's face, okay? So you apply that to each ear, and then you tighten this up around their neck, so just to keep it in place, okay? Then this is what we hook to our oxygen, okay? And each oxygen device in the facilities will be green and be noted oxygen. There'll also be a yellow medical air in at most bedsides. We want to hook to the oxygen. They'll have this thing here. Some will have a little device that looks like a Christmas tree. This one's facilitated here to have humidified oxygen, but this is the prong that we would apply. Okay, we'll just have some humidified oxygen going here. Okay, so you apply that very tightly, and then we just twist this. It's not actually working, but you would twist it. And these numbers on the side here are our liters per minute. Okay, so with a nasal cannula, we are only going to go up to 6 liters per minute. That's as high as we want to go. So if we apply this to the patient and his oxygen saturation does not improve, you can't just crank this thing higher to 15 on a nasal cannula and still think that it is going to work correctly, okay? So once we've maxed out that 6 liters per minute on a nasal cannula, we need to move to a different device, okay? So onto a different device. All right, so we will take this off. Once again, you want to take it off gently too, because those prongs can pull the nares side to side, okay? A semi-equivalent device here would be the simple face mask. You don't really see this used too much at bedside, but the liters per minute can go up a little bit. Anyways, it's mostly used for mouth breathers. So you think if this gentleman here has the nasal cannula in and he's breathing through his mouth, like say he's coming out of post-op and he's asleep and he's breathing out of his mouth, or he has some sort of nasal surgery that's obstructed, he's breathing out of his mouth, this is the device we want to use for that, okay? And we're gonna compare it to the non-rebreather. Okay, so you see how the non-rebreather has a bag on it that we will discuss in just a moment, and the simple face mask does not. Okay, so do not get these confused, they're very different, okay? So this is more equivalent to a nasal cannula. It's kind of the next step up, but we would use it a lot of the same places we'd use a nasal cannula. It's just patient specific, okay? We apply it, put it on the patient's face first. This little metal, you just pinch around their nose for position preference, and then you just put this little elastic strap around them, okay? And they all have the same adapter that hooks to the wall, okay? So we would hook this up to the wall. This goes from 5 to 10 liters per minute. And I'll show you this image here. We've uploaded it to the Canvas page. You'll have this as your resource. I frequently visit this because you need to know how high the liters per minute can go per each device. But it's great to know the FiO2 percentages. Okay, so we'll get deeper in that into lecture. This is going to be more for bedside use. Okay, so I need you to know which nasal cannula we would apply first, which one we would go next, things like that, when each device needs to be used, okay? So now we'll go to the Venturi mask, all right? This is the Venturi mask. It reminds me of Legos. I don't know if you played with Legos when you were a kid, but it reminds me of Legos. All right, so it's a lot like a simple face mask, right? Same adapter here. Now, when you get this out of the packaging, once again, facility specific. You'll hear me say that a lot. When you get this out of the packaging, it is packaged in all these pieces. So you're responsible for putting it together. So if you get it out, it kind of looks like a simple face mask, but you need to add this little elephant trunk, okay? And then you choose which color that you need to apply. Now, you're not expected to memorize which color is which liter per minute, things like that. They tell you on here. I don't know if you can see that. See if you can get it right there. It's a little raised up number. It tells you the FiO2 percentage, but it also tells you which liter per minute. Okay, this is goes simultaneous with your sheet here, talking about FiO2s. So, if we get orders, if this patient needs to come off the BiPAP or something like that, and we're placing this Venturi mask for transport, and they'll say, put him on he needs to be on 50% oxygen or 40% oxygen. Okay, you're thinking, how do I do that? How many liters per minute is that? Well, this little pink one here says 40%, 8 liters per minute. Okay, so that's the one that we would choose. This one's already hooked up, so we'll use this one. You say, this one is 10 liters per minute, 50%. Okay, so you just put that right in there. This inserts into the trunk here. All right, and you apply it to your patient just like you would the other face mask. Okay, headband's kind of loose, so we can tighten it up. And we would connect this to oxygen onto the wall at how many liters per minute it said. So this one said 10 liters per minute. So when we hooked it up to the wall, very important, you would need to make sure that you put the ball on 10 liters per minute, okay? And between this and this little plastic device, it will equivalent to 50% oxygen, okay? So that is more specific FiO2, okay? There's many uses for this. It's one of my favorite devices. We'll get into that later, but this is a great way to specifically control the FiO2 if you have a patient that needs that. All right, so all these pieces need to stay with the patient and their Venturi mask at the bedside. So tape it to the wall, tape it to the stretcher, whatever, because if you need to trade out to a different FiO2, this is our part of that. All right, now we'll go to the non-rebreather, okay? Big thing about this, when you get this out of the package, this is gonna be all tight in a package like this, okay? You need to get it out. Most important thing, before you apply it to the patient, okay? You need this bag to be inflated with air. If not, it's like putting a Piggly Wiggly bag over your face, okay? That's what it feels like. And if the patient is struggling to breathe and they need this, the last thing they need is something on their face to suffocate them, okay? So you would plug this into your oxygen prior to applying your patient. Okay, and once you plug this up, you turn it all the way up. Don't just turn it to 2, don't turn it to 6, all the way up. Just crank it. You don't even have to think. Like that should be your favorite one, okay? And then there's a little flap inside of this non-rebreather. See that little flap? Okay, the way to expedite blowing this up is if you turn it all the way up and I put my 2 fingers over that flap. You see it allows the oxygen to go straight into the bag. This thing will fill up in a matter of seconds, okay? So once I have it filled with air, it will be expanded. Then I can apply it to my patient. Same way I have all the other ones, okay? Now this is delivering 100% FiO2 here. So this does not need to be on your patient all day, okay? This is not a nasal cannula kind of device that the patient will be on for 24, 48 hours at a time. This is we apply this to the patient until we can do something else. Does that make sense? You do not want your patient sitting on this all day, all shift. This is not the device for that. But the main thing here is to make sure this is fully inflated, okay? And make sure your patient obviously is sitting up in the bed, things like that on all these oxygen devices if they're short of breath, okay? The other device, if you see this device, this is not a casual device, okay? This is an Ambu bag. Being an ER nurse, if I see somebody, I wish I could show you what this sounds like. Our oxygen doesn't work, but it has this specific sound to it. And when it's very loud, yes, it's very loud, and I can hear this across the department. And if I hear that noise, somebody's in bad shape. So if you see this, somebody's in bad shape, okay? So this is what you whip out when you need to do a bag mask ventilation. For example, CPR, someone's sat's really low, they're unable to maintain their airway, things like that. Or bagging your respirations to pre-oxygenate them prior to intubation, something like that, okay? Also, this has a bag like the non-rebreather, okay? So if I am just putting this on the patient just like this, he's essentially just getting air, correct? Right? We need oxygen, okay? So before we use this, we would need to hook this up to our oxygen device, okay? And then this whole bag would fill up with oxygen. Once again, you turn that all the way up. You just twist it all the way up. This is fast, okay? They need this. This is a life-saving measure, okay? Then you would apply it to your patient. All right, see how the face mask works? Over the bridge of the nose, okay? This is full of air, and you are bag mask ventilation to your patient. It's just forcing the air in. Now, this is a great time to talk about CPR kind of stuff. So a big time we use this in the ER is prior to doing like an intubation, okay? So I'll put this over my patient's bridge of the nose, use the EC technique, all right? Jaw thrust up. Anyways, so the big thing here is that anytime you're ventilating with this bag, you never want to just crush it in, right? You'll see some people doing it like this. This is way too much air for your lungs, okay? You also want to make sure that you're not barely doing it very quick, because that's like hyperventilating, you know, to the patient. So what you want to do is lift the jaw up and you just squeeze it enough till you see chest rise, okay? Because if you have a great seal here, you're going to see chest rise on the patient, and that's as far as I need to go. You see I don't have it all the way compressed. Obviously on an infant, you would only need to go even smaller. You only go till you see chest rise, okay? But sometimes if the patient is on, if they have a trach, which we'll talk about, we have to pre-oxygenate the patient. If they're on other forms of oxygen prior to doing trach care, you can use this Ambu bag. But if you see this or need to use this, I need you to be comfortable with using this because it's gonna be a life-saving matter, okay? So for example, if this patient, you know, you're monitoring this patient, he's having some difficulty breathing and he's on room air and his oxygen sat is, let's say it's 88% on room air. All right, he's able to communicate with us, telling us that he's short of breath, having some difficulty breathing. You know, obviously as a student, you would notify your nurse. But the first thing that we would want to apply to this patient to try to help him after we sit him up in the bed and do those sorts of things is a nasal cannula. So we put him on a nasal cannula, right? Put him on 2-3 liters. Like I said, the max nasal cannula can go is 6 liters. So if we have him on a nasal cannula, we've given him several minutes, we're trying to coach him through taking deep breaths, things like that, and we've maxed him out at 6 liters per minute, and his oxygen sat is not improving, we do not keep cranking the nasal cannula up, okay? Big no-no, we go to a different device, okay? So now, we don't always have to start at nasal cannula, okay? If we walk in and our patient is unresponsive, and you know, if we have the luxury of him being hooked up to the vital sign machine, if he's unresponsive and we look over there and his oxygen sat's like 55 on room air, can't get him to respond to me, I'm gonna grab my Ambu bag, okay, and perform bag mask ventilation, where you're kind of forcing the air into the patient. One other scenario, I could go on all day. One other scenario is that if you walk into the room and his sat's, you know, in the 70s and he's having a lot of difficulty breathing, and you know, he has all this extensive, you know, lung history, things like that, we can go ahead and put him on that non-rebreather initially, crank it all the way up, apply the non-rebreather, help him get a little bit more relaxed, help his oxygen sats come back up, and then work our way back down. We're not going to make that patient who is struggling with a very low oxygen saturation start at a nasal cannula at 2 liters. Okay, that's very mean, essentially. Okay, so once you start getting more comfortable with the oxygen devices and what their capabilities are and how they need to apply things like that, then you can start working in your head which needs to be applied when they can transition, and things like that.
Ms. Deese, can you tell us about titration orders and how you would do that as a nurse?
Titration orders? No.
Because that's kind of what you're talking about.
Yeah, but what do you mean? Sorry, you're going to stop it.